Look, you can't get away from it. Everyone is talking about Retatrutide like it's the holy grail of fat loss. Well, I've seen the trial data. I prescribe GLPs to hundreds of patients, and there's one number buried in the studies and the hype that nobody, not the companies, nor the influencers, nor the pharmacology bros ever talk about, which is what happens when you get off of it, and why most men and women end up losing the war even when they win the battle. In this video, I'm going to show you how to get the most out of your GLP journey and how to avoid some of the worst outcomes I see every day in my practice. I want to get something out of the way before we go further. Retatrutide is a real breakthrough. It hits 3 receptors, GLP-1, GIP, and glucagon. And the phase 2 numbers out of the New England Journal of Medicine are the best obesity data we've ever seen. I'm not going to pretend otherwise, but I prescribe GLPs to hundreds of men in my practice, and I've seen the same pattern break my patients over and over. GLPs do work. You lose the weight, and then nothing underneath the GLP gets fixed. So when the cast comes off, and with these GLPs, the cast always comes off eventually. They're right back to where they started, or worse. So let's talk about it. Here's what I want you to understand about Retatrutide before we get into what's wrong and how everyone is using it. It's the first peptide that hits 3 receptors at once: GLP, GIP, and glucagon. GLP-1 kills the food noise. GIP amplifies your insulin response and stretches satiety. And glucagon, this is the part that's actually new. It turns on fat oxidation and nudges up your metabolic rate, which is the exact opposite of what usually happens when you lose weight. Semaglutide got people 15 to 18% body weight. Tirzepatide got them to 20%. The Retatrutide phase 2 data shows 24% at 48 weeks. These are real numbers from a real trial, not bro science. The GLPs work. I'm not going to argue it. I get this question a lot. What sets Retatrutide apart from things like semaglutide, tirzepatide, liraglutide? One of the biggest things that we've noticed is that with the addition of Retatrutide, the third receptor that's actually targeted in Retatrutide is really formulated around what's called glucagon. And glucagon helps with fat oxidation in particular. And so what it does is it actually turns up your metabolic rate. And rather than these GLPs that have historically slowed your metabolic rate, which in turn, when you come off of them, you actually have a rebound effect, Retatrutide data has been showing that there's a less negative rebound when you start to come off of GLPs like Retatrutide. So if GLPs work, then where's the problem? Here's the thing. The guys on these trials were on the GLPs. What nobody's studying and what I see in my practice every month is what happens when the GLP is stopped. Every one of these trials measures weight loss while the patient is on the GLP. They don't measure what happens after. I see guys come into my clinic who lost 60 pounds in a year on semaglutide or tirzepatide and come off for whatever reason, from side effects to cost to insurance change, a plateau, and with 18 months, they've gained every pound back plus on average a bonus 15. Here's why. When you lose weight rapidly on a GLP, up to 40% of that weight can be lean muscle. That's muscle. That's metabolic capacity. So the guy who comes off the GLP lighter, but with less muscle, which means lower resting metabolic rate, which means the exact same caloric intake that used to maintain his old body weight, now puts weight back on his new body. He's physiologically set up to regain. The GLP didn't fix anything. It borrowed time. And if he didn't use that time to rebuild the underlying system, he's going to pay it back with interest. I get asked a ton about what happens when someone comes off these GLPs. And I've seen this over and over again when somebody's been 16 to 18 months off of GLPs. Oftentimes, almost without question, they have not only regained majority of their weight back, but then some. There's always this absolute refractory where you see weight comes down on the GLP, and then over time, because they don't change their lifestyle, they don't incorporate exercise, they keep eating the same nutrition. And as a result, their metabolic rate has slowed. They've lost lean muscle in the process. And when they come off the GLPs, over time, 12 to 18 months later, they've regained the weight back and they look the same, if not worse. So if the GLP is real, but the aftermath is a trap, what's the actual playbook? Here's the frame I use with every patient who walks into my clinic asking about Retatrutide. When a guy breaks his leg, we don't tell him to walk on it. We put him in a cast. The cast isn't the treatment, the bone is. The cast holds the bone stable while the bone does what it knows how to do, which is heal. When the bone is solid, the cast comes off. I think about Retatrutide the same way. Your metabolism is broken. Your insulin signaling is broken. Your hunger and satiety signals are screaming at each other. That's the broken leg. Retatrutide is a really good cast. It silences the food noise. It stabilizes insulin. It buys you a window of peace. But the window is not the treatment. The treatment is what you do inside it. Protein at every meal. Resistance training 3 times a week. Real sleep. You get your hormones measured and optimized because you can't rebuild muscle in a cortisol-dominant body with low testosterone. And when the system underneath is actually rebuilt, then you take the cast off. Most guys never do the work inside the window. That's why the weight comes back. So what do I actually do with somebody who comes into my office who is overweight? Let's say they're 250 pounds and they want to be closer to 200 pounds. The very first thing that we talk about is not whether or not they would be a candidate for a GLP like Retatrutide. The very first thing we do is we look at what is the foundation. Where's their framework? Are they incorporating appropriate sleep? How is their nutrition set up? Are they exercising? And then we look at a hormone panel, because if we don't fix the foundation, we will never get the results that we want. One of the analogies I always like to give my patients is this contractor example. If you ask me to build you a house, and imagine that I'm standing at the job site working on setting your block and getting the house square, and you drove up to the area and you asked me if you could show me what windows you want to pick out. At the moment in time when I'm trying to get your foundation set, I do not care about your windows. And I think that's a lot of the same play when it comes to hormone optimization and pillars of your health, from exercise, sleep, and nutrition as it pertains to GLPs. We want to get the cart in front of the horse. We want to ask for GLPs, or we want to get on Retatrutide before we actually took the time to build the foundation and get the framework where it needs to be. Retatrutide is going to change how we treat obesity. I am not arguing against it. But a better tool doesn't fix a broken user. The guys who are going to win on Retatrutide when it hits the market are the guys who treat the GLP like a cast, something you use to buy a window of peace. Do the actual work, and then walk away from it stronger than you started. The rest are going to ride the wave up, and when the cast comes off, they're going to crash harder than they began. So don't be the guy who rides the wave. If you're thinking about getting on one of these GLPs, or you're already on one, and you want to make sure you're using the window instead of wasting it, link in my bio. And that's where I share actual protocols that I run patients through, including what I measure before we ever touch a peptide.